Thank you, everybody, for being here. What happens in September? I'm Thomas Puello. I'm the VP of Growth at Course Hero. And you might be wondering why I'm here talking with this group of very famous and interesting people working in academia, in the world of epidemiology, in the world of healthcare, virology. And that's because I was just catapulted into the scene a few months ago when I wrote a few articles about the coronavirus. You might have heard about one of them or two. Hammer and the Dance, for example, is an example, which was read by around 20 million people and picked up by a few governments who use that as a blueprint for their strategy. And so I thought after 4 or 5 months of this and getting to know a lot of these very, very interesting and much more impressive people than I wanted to know, to chat with them to understand how, from their vantage point, the world has changed, how it was before, how it's changed during the epidemic, and also what's keeping them up at night and how they think things are going to evolve, what we should be paying attention to. So we're going to be having a series of lightning talks, 5 to 7 minutes each for each one of our guests. And I'll start by quickly introducing them, and then we'll go into that. The second half, approximately, of the session will be about Q&A. So if you have questions, you can start asking them right now on the Q&A flow, and my colleague Chris will be helping me filter them and ask them, and hopefully we're going to get into a conversation about them. And our first guest, the one I wanted to start with, is Andy Moss. He's a visiting professor from at NYU. Currently, he's volunteering in the COVID Technology Task Force, and that's how I met him. He's helping build a bridge between the technology community and practitioners in the health, policy, business, and education sectors. He's held senior leadership positions, including advisor and board roles in industries like healthcare, education, civic tech, social ventures, media, new infrastructure. And now he's serving in the steering committee of the NYU Alliance for Public Interest Technology. Andy, welcome.
Thank you, Thomas. I appreciate being here. These are extraordinary times. I think we don't need to say that to everybody for them to appreciate it. I thought I'd highlight a couple of things, just given my sort of eclectic background in both tech and education and some of the work that I'm currently doing. So I've been in the tech sector for about 40 years, and I've experienced all of the rapid acceleration and innovation that we've all sort of seen products come and go and be obsoleted before we even knew what happened. But I don't think we've ever seen anything like it's taken place over the last few months. In March, education literally changed overnight, literally overnight, from classroom to online virtual learning. A small software company, some maybe had heard of, most probably not, is now suddenly used by everybody in all walks of life across the generations. Even my mother has been in a Zoom book club and a poetry reading, all right? And so, you know, it's just staggering the change that's taken place. Concepts like contact tracing, exposure notification became part of our lexicon and things that people are talking about. Groups that are both formal and informal begin building applications. Apple and Google, two of the world's largest tech companies, fierce competitors, in a matter of weeks, collaborated and produced not just a working specification, but implemented it and shipped major updates to their respective mobile operating systems. That's just unheard of. I've been in the tech sector. I've worked on these, specifications. They take years to produce and to get people to agree on. They did it in weeks. Application developers worldwide rapidly adopted it and shipped versions of their software. Governments, who notoriously move at snail's pace, allocated funds and actually built some of the applications as well. Researchers, we've seen share critical research long before they might have otherwise. And it's led to faster cycle times on research on treatments, vaccines, and other ways of combating COVID. So, not everything that took place was great, not all of it was useful, and there was enormous waste and inefficiencies, but innovation is often messy. This was just done at a scale and in the public view as we've never seen it happen before. It's actually quite breathtaking just to have experienced it. And while it's easy to criticize some of the individual efforts, and we've seen things materialize around the U.S. and we've all read press reports on, this didn't manage privacy well, or this one cost too much money. If you look at it in aggregate, in the broader context, we have to appreciate the effort for what it is, and that's truly an amazing human ingenuity and resolve on a global scale that we've never seen. People are collaborating in unprecedented ways. Even the COVID task force that I'm been party to in the last few months, I never knew any of those people prior to joining, and we're about to run our third event tomorrow. We've had conversations with some of the largest software companies, healthcare professionals, government policy people, and it's really just all because everybody said, how do we get in it and fix this thing? On the education front, how we teach has changed. How students learn has changed, and how institutions create environments conducive to learning is changing literally as I say these words. You and I met because of the effort that I'm leading tomorrow on safely reopening education. Now, so that's going to address policy and what the emerging sort of a virtual hybrid classroom looks like. It's also going to talk about experience outside of the classroom, as what happens in school isn't just what happens in the class. That's really important for those of us that are in education to keep in mind as they're preparing for what comes next. So, as we as educators plan for the fall and beyond, it's imperative we factor in more than just the actual syllabus and the curriculum. We have to address all of the nonverbal, ad hoc, informal communication that's a fundamental aspect of of the educational experience. And for this, we actually need more innovation. As impressive as it's been, as all of the technologies that have evolved pretty rapidly, we need even more. And so we're fortunate, though, that many of these technologies have sort of incubated over the last few years, because had this pandemic happened 3 or 4 or 5 years ago, we couldn't have switched as quickly as we have. And so, it's important to take note of that. But while it can be a little frustrating day to day that the experience of teaching and the experience of learning is not what we would like necessarily, it does actually work. But it works for many, but not for all. There are many inequalities in our education system that have been, in some respects, highlighted and in other ways exacerbated by this new sort of virtual normal that's evolving. We can look around the country and see bandwidth isn't even everywhere. Not all students have quiet space at home to work. Many don't even have computers they use, individually. They have to share them with family members. So schools themselves don't all have the funding to install all of the new equipment, whether it's video equipment or other things in the classroom. And many of them don't even have personnel to know what to install. And so while overall, I think we've done an amazing job and responded well, we still have a long way to go. As it appears that we're going to be dealing with this sort of COVID challenge, certainly for the foreseeable future, and probably then, the time past that, because, as some policymakers don't want to recognize the data, there's a lot more that we don't know than what we do know. And so we have to continue to innovate. We have to continue to adapt very rapidly. And we're just getting started, frankly.
Thank you.
I'll just pause there and stop. But
thank you, Andy. Yeah, and so many threads to pick up on in the conversation later on. Thank you so much, Bob. Tell us, what do you think? Oh, sorry. Before that, let me just introduce you. I forgot that. In fact, I got to know Bob through Twitter initially because everything he ever wrote, I think, got into my feed somehow, retweeted by somebody. And then I was honored to have a couple of my tweets retweeted by him. And so, well, that's interesting. And through these months, I have seen how much respect any of his opinions has gathered through Twitter. That's my vantage point of him. But obviously, after that, there's much more. Right? He's the professor and chair of the Department of Medicine at the University of California, UCSF, San Francisco. He's also the author of 250 articles and 6 books, and he's a frequent contributor to the New York Times and Wall Street Journal. He's been 13 times in Modern Healthcare magazine, ranked as one of the top 50 most influential physician executives in the U.S. And as I mentioned, right, his Twitter following is crazy, more than 100,000 people, more than 50 million impressions over the last few months. So yeah, Bob, I'd love to hear how you've seen from your vantage point of the crisis and what's coming.
Thanks, Tomas. It's an honor to be here. And I have to say, when I read The Hammer and the Dance, it was an epiphany for me to help me understand the predicament we were in and the things we needed to do to get things under control. And obviously, it's quite sad that we have not done that, or certainly not done it as well as we could have. I'll give you my impressions as from my vantage point this week, because I'm on clinical service taking care of patients in the hospital. And so there are others here that are world experts in other facets of it. So I'll focus a little bit on clinical care. First of all, the scene in the hospital, I can tell you that in March, it was crazy. Here in San Francisco, we were just waiting for a tsunami. The feeling was standing on a beach, seeing the top of the waves and knowing that we were going to get slammed. And miraculously here in San Francisco, we never did. And we still really haven't. There's a mild uptick in COVID patients over the last month. But as people and I and others have talked about, California surging. California is surging, San Francisco a little bit, but not that bad. In the entire city, we've had a total of 58 deaths since this thing started, which is just absolutely remarkable when you think of New York having over 20,000. In addition, in February, March, everybody's hair was on fire. It was like, where are we going to find PPE? How can we staff the ICU? How can we staff the ER? Am I going to get sick? Am I going to die? Now it's much, much calmer. I walk around with, I have my surgical mask and my goggles. I don't have those on now because I'm in my room alone, but everybody in the building has them. And I have to say, I feel safer here than I do in the supermarket. All of our patients are tested when they come into the emergency room. And so by the time I see them, which is after they're admitted, I'm quite confident that they don't have COVID. So it's much calmer, much more sane environment than it was. We talk about sort of how we will get to normal and can we get back to normal. And I think it'll be interesting because I am encouraged by what I hear about vaccines. And it seems likelier than not that we will have a vaccine, at least one vaccine that works by the end of the year. But it's going to take an awfully long time to get that injected in the US into 330 million shoulders, get it distributed. And as we know, a fair number of people may choose not to take it. And so getting back to normal is probably going to be some combination of a vaccine and also figuring out ways of taking care of patients more effectively so they're less likely to die. And we've made some progress on that. It's fascinating if you looked at the early reports coming out of Wuhan, the mortality rates of patients who were sick enough to go into the intensive care unit and get on a mechanical breathing machine were about 90%. 9 out of 10 of the people who went on a mechanical breathing machine for respiratory failure died, to the point that there were people beginning to discuss whether they should even be offered mechanical ventilation, whether it was almost futile. By the time you got to New York, it was more like 40 or 50%, which is sort of more in the range of what we see for patients with really bad pneumonias and something they called ARDS, the acute respiratory distress syndrome, which is what that most resembles. But even that is not so good. If I get sick enough to be on a mechanical breathing machine, I have got a 4 out of 10 chance of dying. In San Francisco here, we're seeing numbers that are more like 2 out of 10. And I think the reason is 2 things that are better than they were in the beginning. One is we have found some medicines that work. Really 2 of them that have been definitively proven to work. One is an antiviral medicine, remdesivir. The other is a corticosteroid that suppresses the immune system, dexamethasone. We've also figured out some techniques, and the main one is proning, putting people on their belly. That seems to improve their breathing. There are a couple of other medicines that might work. For example, here we also give people convalescent plasma. We give them antibodies from other patients who got infections. The evidence for that is a little softer, but my guess is it will turn out to work. And the other thing that probably makes a difference, and the reason our mortality rate here in San Francisco is significantly lower than what they saw in New York or in Italy, our doctors are not better. They're pretty terrific. Our nurses are not better, although they're pretty terrific. If the system is overwhelmed, the outcomes are worse. And so part of what gives me hope for where we might find ourselves in the middle of 2021, and that passes for optimism these days, we might get out of this a year from now, is that if we have a vaccine that many, if not everybody gets, but high-risk people get, and it works 50 to 70% of the time, if on top of that, we have medicines like the two that we've proven to work and maybe a couple of others that work, and that seems likely to me. We've discovered 2 medicines that work in 4 months, no reason to believe we won't discover some more. If we prevent hospitals from getting overwhelmed so that they're able to provide the kind of doctoring and nursing that the patients need, I can imagine that the combination of all of that would lead to the risk of getting sick and dying being comparable to that of the flu. I want to be super clear that the idea of COVID is like the flu is wrong, completely wrong. It's become partisanized, and it's mythology, and it's a canard, and it's actually incredibly dangerous. COVID is probably 5 times worse than the flu when you add up all the numbers. If we could lower the probability that COVID would kill you by 5 times, we know that we tolerate the flu. It's bad, I don't want it. People do die. I've taken care of many patients who died. But if we can get to a level of illness and death that is comparable to the flu, we go on with our lives, and we've done that for the last 100 years. So that to me is sort of the hope, that we'll have a combination of things, a vaccine that's partially effective that a lot of people get, medicines that are more effective than the ones we have today, other techniques like proning, where we just started to learn tricks of the trade by doing this a lot and figuring out what works, not getting overwhelmed. And when we get there, I think we could reach a stage that resembles normal, which means we won't wear masks, we'll be able to go to baseball games and such. So that is my optimistic hope for us about a year from now. You're on mute, Tomas.
Yeah, thank you. I've seen the fatality rate numbers going down, percentages, and it's very, very encouraging. And what you say is one of the key reasons for that. So hopefully that continues. Thank you, Bob. John, I met John. I think we met through Twitter too, right?
So yes.
Yeah, and so John is an innovation theorist, and he founded the Nosta Lab. His focus is on the diffusion of innovation in complex systems like healthcare technology. He's a member of the Google Health Advisory Board and a founding member of the World Health Organization's panel on technology experts. John, welcome.
Thank you very much, Tomas. It really is a pleasure to get a chance to chat with you. You know, I was challenged when I looked at this illustrious panel. What the heck am I going to say? You know, I spent a little time in medical school, but didn't complete it. Spent some time in marketing, but now look at the diffusion of innovation. And what I'm seeing generally is certainly what Andy said as breathless. We are seeing unique fundamental changes in the world today. And you know, in my school of thought is about exponential change. We talk about that all of the time. But I think we're seeing a triple inflection point characterized by 3 interesting things. I want to talk about them, and then I want to talk about them 100 years ago, because there are fascinating parallels that I think we can tease apart a little bit. But that triple inflection point is number 1 about the availability and the emergence of technology. And I include life sciences and pharmaceutical science in that. The technology is here, it's available today, and it's extraordinary. That's the first change. But as we all know, a good idea doesn't really get adopted or adapted into mainstream life or even clinical practice. So that's one area that is important. But add to that the other layer of legal and regulatory approval. And we could just look at things like telemedicine and how difficult it was to get a telemedicine approval across a state line or areas around the world. So we see governments in a much more cooperative posture, at least some of the time. So that's the second element that I think is real interesting for me as a sort of an innovation theorist. So it's technology, it's a regulatory government approval process that's facilitating some of this discussion. And then the third one is this social imperative. And sometimes you can call it a moral imperative, but it seems to be the right thing to do. And those 3 add up to a very, very unique time in human history. And I would argue maybe it's fair to say that the 21st century began with COVID. I think that may be a reasonable way to sort of frame up what happened before and what happened in the future, because this clearly is that triple inflection points that is redefining many aspects of science, medicine, drug development, societal issues. But you know what really interests me is it kind of happened already 100 years ago. Now, everyone became a little bit of a Spanish flu epidemiologist, we all sort of magically discovered that there were 3 peaks and all sorts of things like that. Interestingly, the principal cause of death in the Spanish flu was a secondary bacterial pneumonia where there were no antibiotics. But what happened 100 years ago was sort of the emergence of that century. And I see tremendous parallels. So the question is, what happened in the year 1900? Nothing happened in the year 1900. But around 1915 to 1920, we saw the emergence of some fundamental changes. The first was significant social strife. And that was things like the Russian Revolution, things like World War I, but also the emergence of Spanish flu. And that was something that defined part of that decade and that century. Similarly, there were a few others. The emergence of technology, the discovery of the mass of the electron, the development of small data, the emerging science of vaccines happened at that time. And also with it was this grand sense of wonder that we as a society, we as scientists, we as citizens can create a new future that is better, that can solve some of these existing problems, not the least of which was the emergence of Spanish flu. And finally to that, which I think is very, very interesting, just as it is occurring today, it occurred in 1917 and 19, and that's the emergence of the power of the individual. We saw something emerge then that maybe we could talk about it in terms of engagement, perhaps as the Russian Revolution, but also in terms of child labor laws, things like women's suffrage. These were the causes of the day. And that's exactly parallel to what we're seeing today. And that's defined in the notion of the quantified self, that I can quantify my steps. I can quantify my temperature. I can quantify various things. And then the collective, through social media, through search, tracing, things like that, we now have this power of the individual. And that's something that we see on Twitter and society sort of taking control of it. So for me, it's a really interesting time. It's certainly a sort of a triple inflection point, but it harkens back to something that happened 100 years ago and gave birth to a new century. And I think that's what we're seeing now. So I know it's a bit of a philosophical perspective, but I think that the 21st century began April, May, pick a time, but it certainly is being born now. It's coming to life in new ways.
I hear you, and I saw another video of you arguing that in that direction, that coronavirus matters a lot in the short term, but not as much in the long term, and that these
I stuck my neck out in that video, didn't I?
No, I think it's a reasonable point. I don't think there's anything as important as the coronavirus right now, but in a few years, I think the repercussions, the social repercussions, are going to be.
I think, as Bob said, if we can get the mortality rate down, if we can make this into a functional chronic disease that's manageable, a lot of this social urgency is going to disappear, and we're going to get back to our lives. And it's my hope that 10 years from now, we're going to call it the coronavirus. And then we'll say, oh, no. But what will stay in place are those social, cultural, and technological changes that got a foothold now.
Thank you, John. And we'll talk more about that.
Mm-hmm.
Angie, welcome. I also met you in this crazy time, in your case through Andrew Refkin, who's also here. We're in the same panel. I had met you before, also through Twitter, because you also have an amazing following, and completely deserved, thanks to your unique angle, which in your case is that of virology, right? So you are a virologist at the Columbia Mailman School of Public Health. And so from that vantage point, I'd love to hear how the world has changed from your perspective, and what's important, how it's going to change in the future.
Yeah, so it's definitely changed a lot. I mean, I agree with John completely that this is a really interesting time, particularly to be a subject matter expert in this field. So prior to the pandemic, I study emerging viruses and the host response to them and how they cause disease. So I had already written several papers on MERS coronavirus. I had a funded grant to study MERS coronavirus, as well as Ebola, several other emerging pathogens, influenza, and things like that. So this was right within, squarely within my area of expertise to contribute. And of course, like many of my colleagues in virology, I too have gotten funding to do coronavirus research on SARS coronavirus 2. But there's still a lot that we don't know about it. From my perspective, one of the things that has been the most interesting about this is realizing not only how little we know about this novel emerging coronavirus, but how little we know about viruses in general. And one example of this that I think is really relevant for the overall topic about going back to school is how these viruses are transmitted. So there's problems with the nomenclature that even experts use to discuss this with each other. So I could say droplets, inhaled droplets, and that's going to mean something completely different to somebody who's an aerodynamic engineer, fluid aerodynamics person. It's been really challenging to try to communicate to people, actually, even with influenza, which is a completely different virus, or SARS Classic, which we've known about for 20 years and was studied fairly heavily after the original emergence of SARS in 2003, there are still a ton of open questions about the fundamental way that these viruses behave, the way that they infect people, the way that they cause disease. And it's been really, and sometimes a very fun challenge, sometimes a very frustrating challenge, trying to communicate that uncertainty to people. One thing that has been really wonderful is the ability to collaborate across disciplines with, like, I don't think I would have met you, Tomas. I don't even know if I would have met Andrew, and we're at the same institution. He's also at Columbia. And it's because really of all these different new ways to communicate. And I actually joined an emerging viruses consortium completely based on a Twitter interaction that I had with the PI of that consortium. So I'm forming collaborations using social media and, you know, talking to people through more conventional forms of media. I certainly, you know, have read multiple articles that have quoted Bob. I'm familiar with his Twitter feed. We all tend to, I think, see each other. We all sort of intrude into each other's ecosystems because of this. And it really has been wonderful in the sense that I've learned a lot about fields that are adjacent to mine. So clinical medicine. I really knew very little, actually, even though I study viruses that cause ARDS. I really knew very little about clinical practice, and I still obviously don't know enough to treat a patient or opine on that, but I've learned so much from physicians like Bob who are communicating about that. I've learned a lot more about epidemiology, which a lot of people think virologists and epidemiologists are the same, and we're definitely not. I've really learned a lot about that and how to judge a good epidemiological study from a bad one. One of the things that also has been incredibly useful and I think has also been harmful in some ways is the way that data is coming out now. So preprint servers and the very unfortunate habit of announcing data by press release, they can be good in the sense that people are getting information as quickly as possible and people can make actionable decisions both on research and in terms of their clinical practice based on that. But the problem has been, of course, communicating some of those results has sort of fallen flat. So I end up, for example, explaining to people that a mutation in the spike protein doesn't necessarily mean that the virus is more transmissible or that a vaccine is not going to work. So it's created a lot of opportunities, I think, to educate people, which is great. And I think we should apply those types of communications to the way that we approach education going forward, especially since, as Andy pointed out, you know, we're going to have to keep doing work to make sure that people are getting equitable access to education, and not just about this virus, but about education in general. I think that it's been a lot of really good things have come out of this, and a lot of pretty bad things have come out of this. But I share everybody's hope and John's hope that, you know, these social, cultural impacts that have resulted from this pandemic will stick around. Hopefully people will still remember that this was called a coronavirus so that they invest more in pandemic preparedness for sure. But I also share Bob's hope that we'll be able to come back to some semblance of normalcy in a year or so. I think that it's really important to manage expectations about how quickly that's going to occur. I mean, even though this week we got very encouraging news about one of the vaccines and its efficacy in non-human primate study, it's still going to be months before that vaccine is going into everybody's shoulders. So I'm hopeful. I'm also pessimistic and trying to manage my expectations. But I'm happy to talk about any of the larger virology questions that anybody has, and to continue this discussion after everybody's had their opportunity to talk.
Thank you.
So thanks
Thank
for
you.
having me again.
Of
on
course,
this panel, Tomas. This is great.
And thanks for coming. And I have a bunch of questions, obviously, for you. I think just one of them that you very quickly that you mentioned, and that might still be relevant to the audience, is the difference between epidemiology and virology. I think you've talked about it a lot, but maybe not everybody has heard about that.
Yeah, so a virologist, well, there's multiple flavors of both epidemiologists and virologists, but virologists generally study the virus itself or how it interacts with its host. So cells, molecules, immune responses, things like that. Epidemiologists study how diseases spread within a population. So infectious disease epidemiologists are looking not so much at individual people, but they're looking at, all of New York City and how many people infected other people in New York. So that's the difference. And, both epidemiologists can comment on usually basic virology and immunology. I can comment on basic epidemiology. But if you ask me, how is this model calculating R naught across the US in these particular counties, and what data are they using to do that, and what kind of statistical model are they applying? I have no idea what I'm talking about, so I'll refer you to somebody who does.
Thank you, Angie. Our next guest is Rikita Merai. You work also at UCSF. You're a technical advisor at the Institute for Global Health Science here at UCSF. Before UCSF, you were a health scientist at the CDC, where you managed projects supporting Million Hearts, National HHS initiative around heart disease and strokes. And now you've been also thrown into this coronavirus world through contact tracing. In your case, you're leading a team of contact tracers in UCSF. So welcome, Rikita.
Thank you, Tomas, and thank you for giving me the opportunity to speak amongst all these great panelists. So as Tomas mentioned, I've been working closely with the San Francisco Department of Public Health to roll out their contact tracing efforts. I actually started out as a contact tracer. So in March, my small team of global health researchers, we all got together, we started making phone calls. We even, tried to set up the whole phone system, all of that, like things that we're not really, used to doing. But we made those phone calls, we called close contacts, we, let them know they were exposed, we referred them to testing, we provided isolation and quarantine guidance. We also, provided food and housing support. And, at that time, we really didn't have a data collection system. We really didn't have any, training materials or guidance documents or anything like that. Our system really just wasn't fully built, and it was just, really just all hands on deck. But now, looking, back, what we're seeing now in July is that we've really scaled. So we have over 200 contact tracers trained and working in the city right now. And most of these tracers are actually city employees. So, just going back to the whole collaboration piece, we've worked with city employees that are, not able to work right now. So librarians, for example. So we have tons of libraries in San Francisco. So we've sort of taken that workforce and retrained them into doing contact tracing, and they're actually pretty great because librarians are very resourceful and they've really picked it up. And so a lot of the staff are librarians doing this right now in the city. And then we've sort of, it's just been really amazing to see this all come together. Like now we have a data system, we have metrics to monitor our progress, we have quality control measures, we have all of this stuff where it's just in the matter of a span of few months. And I sort of say we've sort of built a sizable company in the past few months, considering we have, you know, a workforce of over 200 people. But, you know, I think looking at things right now, and, you know, Bob mentioned there is an increase of cases in San Francisco. And so while the hospitalization, you know, rates are the death rates haven't gone up as much, there are still, you know, increase of number of cases. With that, there's an increase in number of contacts. And so, you know, we've really had to mobilize and try to address this surge that we're calling it. So, you know, in San Francisco, more than half of the positive cases actually have happened after June 1st, so after reopening. And with that, and looking at those cases and contacts, we've sort of seen the exposure, like where people are being exposed has changed. So, you know, before June 1st, it was mostly within households or workplaces, you know, considering that most things were closed. But now we're seeing that things are getting a little messy. You know, people are getting exposed in the community and other settings and things like that. And so we're trying to really figure out how to respond and how to figure out what to do in those situations. So in San Francisco, in the health department, we actually have community hubs. And so there's different community hubs working for different sectors. So there's a workplace community hub. And in that workplace community hub, we actually work with employers. So if there's a positive case that went to work, the workplace hub calls that employer, gets the close contacts, provides guidance. What should they do? How should they clean? You know, should they close? All of those questions that's, you know, provided through the health department. But what we're seeing now, we're seeing a lot more cases within summer camps. So in San Francisco, summer camps opened up June 1st. And we actually, while there's guidance set in place, the guidance, I think, you know, it's children between 6 to 17. They can, you know, camps can only last 3 weeks. And also there's a maximum of 12 students per camp. We've sort of seen that there has been an increase in transmission in the past few weeks. And we have within SFDPH, within the health department, we do have a community hub that focuses on schools and summer camps. So it's the school and childcare site hub. And what sort of happens and the way that it works is that if there is a case in the school, if there's a case in the summer camp, the school has to notify the health department, and that's where the health department and the school, they sort of work together and develop a response plan. And this is, you know, they'll sort of figure out what the situation is at the school, you know, and this sort of, and figure out how to give the guidance based on that situation. And so each school is very different, what we're seeing. You know, each day is very different. The recommendations are changing every day, so it can be quite challenging. And just sort of to give a little bit of perspective on the different types of situations. So you'll get schools where there's several cases, or you'll get schools where there's just one positive case and it's a staff member, or you'll get schools where there's, you know, cases only amongst the children and not the staff. So what does that mean? So you really have to get into the weeds and really figure out what is the right guidance and how to go about it and how we can have a tailored response that's effective. And some questions that we're, you know, answering right now, which I thought might be helpful just to bring up to the group is, and things that we need to think about collectively is, you know, what's the definition of a close contact in a school? Is it everyone in a classroom? Should all close contacts quarantine for 14 days? Or is it, you know, just the ones that are likely to transmit the virus, like staff members? Should children get tested? And if they test negative, should they come back to school, or should we wait till the incubation period is over in 14 days, even if they test negative? And then how should you respond if there's several cases? You know, at what point do we consider it an outbreak at the school? And so what is the definition of an outbreak at a school, and how does that differ in different settings and different types of schools? So I think, you know, those are questions, and maybe one of the other important questions is, you know, what is the best response, you know, response strategy that we could implement that has the least amount of harm to the school, to the community, and the students. And so that's something to think about. And I think, you know, we really just need a collective data-driven approach, work hand in hand with the health department and schools. And, you know, I see that happening more and more, you know, every day. And I can see that more in September. I feel like this will happen in San Francisco and hopefully across the country. So that's sort of the perspective of school.
Yeah.
I did want to just leave with one quote on the contact tracing perspective and just sort of giving the perspective of contacts. And so actually got this quote a couple of days ago from a contact that one of our team members called. We called her and told her that, you know, she was a close contact and got her tested, or got her an appointment for testing. And she called back and she said, you know, I wanted to cry, but of happiness, you've provided extraordinary assistance to my family. Nobody's ever given me food or cleaning supplies. We all got tested and we're all negative. Thank you for the work that you do. And so, I think this is a really important piece that needs to be built into the response strategy as we open up. Thanks.
Thank you, Rikita. And we'll talk about some of the things that you're mentioning, children for sure. Before that, there's one specific thing that I wanted to ask you. You talked about being data-driven, and it sounds to me like the number one number that really matters in your world is, out of all the contacts of people we know are infected, what percentage of all of them do you think are properly quarantined?
It's a great question, and we're trying to work that out. And basically, it's hard, right? So you tell someone to quarantine, how can you really measure that someone is quarantining, right? You can have a passive approach and do it by SMS and ask them if they're quarantined, but how many people actually say no? So what we're sort of doing is actually looking at how many have tested positive out of the contacts that, out of the close contacts, and looking at it at that angle and looking at their exposure type and things like that. So I don't have quite an answer. I think that's something that we're still trying to figure out right now.
Yeah. And thank you, Rikita. And that was my guess, actually. And it is one of my concerns. I'll talk about that later. Fascinating. Thank you, Rikita. And I think the next one is Andrew. Andrew, right? Is that right? Andrew, we met because he invited me to his podcast a couple of months back, where I met Angie too. And I was very impressed with, in his case, his very strong journalistic background, 35 years of experience writing, mostly for the New York Times, around environmental and environment and science. You're also the director and I think the founder of the Earth Institute initiative on communication and sustainability at Columbia University. Where you're working to obviously fight climate risk. So, Andrew, thank you for being here.
Oh, it's just great. Can you hear me okay?
Perfectly.
I might see if I could show a couple things. Can you see stuff?
Perfectly. We can see you. We can see it.
So yeah, 25 of my years were spent as a conventional journalist, magazines, books, writing about the Amazon rainforest, writing about global warming starting in 1988. It kind of looked like this. This is my 1988 cover story on global warming. Cigarette ads on the back and climate concern on the front. So, and then I stumbled into the internet like we all did. And I started a blog at the New York Times. And that was in 2007. Even I was still a newspaper reporter, and no one said, "Hey, Andy, we need a blog on sustainability." It just felt right because it felt like it captured the dimensions of issues like climate change and biodiversity loss and pandemic risk, which I wrote about a little bit. And then I was really in love with the internet. And by 2012, as you can see here, if you can see that right screen, you can see I was writing about the noosphere. And I use that word building on noosphere, which is a Greek word from Teilhard de Chardin, and a Russian geochemist in the 1930s saw this planet of the mind, like here we are. And here we are right now in the planet of the mind. So I was very excited about all that. Twitter was great. And then the noise factor and the storm factor and the disinformation factor, just like these they're like extreme storms in the climate, you know, they were disruptive and shocking. And this is before COVID-19, and I kind of got disenchanted with the internet. And then, so I started the center at Columbia to look at the bigger picture of information and response. You know, how do you actually make information matter in the online environment mostly? And we were doing, you know, I started last fall. We're working with Maya Lin, very famous artist, on a 3-dimensional digital thing. And then boom, along comes COVID-19. And what I did, I went in March, I did what I think everyone here is describing. I adapted, you know, we all are adapting. And what I'm trying to do now is to serve as an intermediary. I'm not a genius or a smart person at anything, but I know a lot of people through 35 years and thousands of interviews, and even more now through the connectivity online that allows me to find Angie Rasmussen on the same campus, even though I would never actually meet her otherwise. Literally, I guarantee you, it would have taken a year or 2 or 3 or 4 before. There's a digital storytelling lab at Columbia that I didn't know about till 1 month ago. And you know, that's what I do. So I mean, I started this StreamYard webcast, which is how I met Tomas, how I met Angie, how I've, you know, met dozens of people now and trying to facilitate conversations going forward. And John, I think, hit on this, you know, this notion that maybe this virus has done us the favor in the long haul after some huge disruption and cost and pain and tragedy, to stimulate us to really look carefully at how to maximize the upside of all these tools. The downside is there, Cambridge Analytica, and this election is going to be a nightmare if it even comes off. And everything we look at online right now is from the edges of arguments. We see Portland from one side and the other. It's the Trumpian lens sees it as, you know, anarchy, and the progressive lens doesn't see any of that. They see it as something else. So now maybe, because we're being enforced to think about the reality that having a fully functional, equitable society serves everyone. You know, as those patients being seen in emergency rooms, if they're orderlies at hospitals or home care workers, or, you know, all the people we rely on but never really adequately engaged in our economy, we're screwed going forward. So I started this thing. It's on Twitter and Facebook and YouTube and LinkedIn. And one of my first one, this is back in March 12th, was with someone I already had known. These skill sets that teachers and learners and innovators and connectors are using an overdrive right now, they're already there. This young woman, Sarah McNulty, is a squid biologist, a marine biologist at UConn, who created Skype a Scientist as a hashtag like 4 years ago. And I was very excited about that. And I thought, and Skype a Scientist is basically a way to raise your hand and say, I'm studying squid, or I'm over here, I'm an astrophysicist. I could be in any classroom on the planet with connectivity. So let's just arrange that. And so I did a thing with her. And then of course, here's Tomas, here's Angie, here's Howard Frumkin, who's a great, he was one of the leading public health officials in the United States in the Obama administration. And we're looking at, I'm sure many of you have seen this cartoon that came from New Zealand, from an illustrator in New Zealand, who teamed up with a science communicator there and created a graphic that's probably as viral as Tomas's Flatten the Curve essay. Millions and millions and millions of utilizations, translation into more than 10 languages now. And think about the impossibility of that becoming a global phenomenon even 2 years ago, 5 years ago. So that illustrates just so powerfully the upside of where we're at. It's a great moment to think the way John was talking. Teachers are scrambling right now for resources that can make a screen engaging and not stultifying.
Yeah. And
so teachers need tools. It's not tools, they need incentives and awareness. Way back in March too, Seamus Khan, he's the chairman of the sociology department at Columbia, tenured faculty, doesn't have to do anything, right? Theoretically. And in March, almost overnight, he created this online learning space, and he It was called youthremote-learning.com, and he had a bunch of people just dumped in a bunch of syllabi. They said, I could teach this to, with a calendar. And as you could see here, he's teaching young kids to learn how to be an ethnographer. Like, you're in the middle of a historic calamity. What can you do right now, wherever you are locked away? What can you do to chronicle the moment in a way that will be valuable to historians and students of the future? And that capacity that Seamus manifested there is something I would love to be able to spread and propagate. And I've been doing this in various ways in my webcasts. There's this young guy who created Earthrise Education, which is a portal for satellite imagery collected by private satellites that's public domain and NASA of the world, and creating a way for students to actively engage in learning and doing at the same time, using that footage, using those images and studying them. And these students, this is before lockdown in like February, and in March during lockdown in Massachusetts and Iowa, students were using satellite imagery to identify gold mining intruding into an Indian reserve in the Amazon rainforest. And that resulted in a story in Reuters, a Reuters article that resulted in more of a crackdown on that practice. So, and that totally excites me, because it says, if you want to make screen time something other than a chore, what can we do right now, whether the data are data around coronavirus or data around Amazon burning or data around your local wetland or your neighborhood's success in dealing with aspects of the economy around the virus. If we make it an enabling tool, and this is all there, it's all there, then we really are on a path toward reinventing education in ways that can be sustained and aren't just a patch. I hope people aren't thinking of this as like some temporary patch before we get back to quote unquote normal. As I think everyone here expressed it very powerfully. This is not a question of getting back to normal. I want to show one last slide. This again, we all know that the Johns Hopkins dashboard, which started in January, right as the early signals were emerging from Wuhan. The origin story tells the story I'm trying to tell here. It was basically Ensheng Dong, who was a PhD candidate there, and his boss, Lauren Garber. That night, they saw an early tweet by, he's a very popular face on Twitter now, an epidemiologist, saying big bad things are happening, get ready. And they threw this together overnight. And now it's had billions, with a B, billions of views. So they're in the applied engineering department there at Johns Hopkins. They didn't have to do that, but they did. And it became an iterative, expanding capacity. So I'm kind of like bummed and excited at the same time. And I think with a lot of attention, we can really normalize some of what we're doing right now.
Thank you, Andrew. There's so many things to discuss about these. What you're saying touches also on some of the things that John mentioned. And so I have three topics to comment on. I'm not going to comment on all three at the same time because I'm conscious of time, and I know that Andy needs to leave, and I want to hear his reaction before that. So the one that I wanted to start with is actually the one around the future. And to me, as John, you were saying, the impact of the ramifications of the coronavirus are going to be dramatic of the 20th century. We've talked a lot about remote work and remote schooling, education. I think both of these factors are going to completely change, not just these work and education, but also real estate and politics and things like that. And the way I think about it is both the office and school or campuses are bundles of services that we never even realized they were providing. Right? In the case of the office, for example, the bundle might be it's a place for you to work alone, but also a place for you to meet other people. But it's also an easy way for you to tap these people. It's an easy way to see whether people are working or not. It is an easy way to get food. It's an easy way to have serendipitous encounters. It's for some people, it's a way to meet other people for love. And so you have all of these needs that we never even thought were bundled in the office. And the same thing happens for education, right? There's obviously the learning side, there's the credential side, but there's also the life experience side of campus. There is the fact that if you go physically to class, you can social pressure people into listening, into paying attention. So you have all of these needs that are fulfilled by campus. And if we're going to take these things remote, we need to unbundle each one of these services. And each one of these services needs to be catered to by a different service, right? And so the only way both work and or academia might be brought online is by understanding all these services, unbundling all these services, and having a technology that is superior to the service or the need or the way that each one of these needs is solved physically. And so to your point, Andy, I think one of the things that you mentioned I think is really, really interesting is, for example, that nonverbal communication, right? Those dynamics that are happening in class that you can't quite replicate today online. And so what are these things that you've lost? What are you seeing as emerging ways to replace them? And do you see a potential for some of these replacements to be better than the original solution?
Yes. Yeah, that's a great question. You know, this is one of those places where I'm not sure technology has caught up with human need. You know, the element that's missing, or that we are losing as we've shifted to this virtual classroom kind of experience, has to do with spontaneity as well. And you know, when you're walking around a classroom, you pick up visual cues that your mind doesn't even recognize that you're picking up, but you see a movement, you read a facial expression, and you can react to that in real time. And it's not clear to me yet if there's a mass solution to that. Certainly things like, you know, virtual reality or augmented reality hold promise for those things, but then those just seem to exacerbate some of the inequalities that there are. Because if we have kids that don't even have a laptop and broadband bandwidth, you can't really look at things like AR and VR as substitutes for that human connection. So I think this is an area that we're going to have to spend a lot of time thinking about. I have not yet seen, I didn't want to call it a solution. I haven't even seen an inkling of
anything that looks like
how to replicate that spontaneous human connectivity. And that's also replicated not just in classrooms, but that's where innovation comes from in the office place as well. It's the, you know, we used to talk about it in terms of the water cooler, right? It's the spontaneous running into somebody, you know, Andrew and Angie didn't know each other, you know, but so many people in office spaces don't know each other, but yet they pass each other at the coffee machine, and suddenly, you know, you have this conversation that might not have started otherwise. And so it's those kinds of interactions that I'm afraid we're losing as we rapidly adapt to this, but I don't know where they're going to come from. And I see John really wants to jump in here.
You know, yes, I agree with you 100%. My concern is that, well, first of all, and I'm going to look at this from the perspective of a traditional classroom scenario, but also from telemedicine, because I kind of live in that healthcare space. And what I find is that what we're doing is translating an office visit to the screen, and which is kind of weird. There's such a richer experience. Think back at the time of the early websites, where they used to take a brochure and translate the brochure right to a web, and how horrible those. And then all of a sudden there was this thing called the UX and the user experience. I don't think we're adequately transferring the EDX, the education X, or perhaps the CX, the clinical experience. So I don't know. I mean, I'm gonna again stick my head out on the chopping block here and say that perhaps technology can make us more human. Perhaps there are elements of our very existence that are limited by our sensory awareness. I mean, my dog can smell 50 times greater than we can. Now, does he have a more definitive worldview? I think maybe in some sense. So to me, I think that there's going to be very, very interesting kind of evolution here. We're setting the bar for the human engagement, maybe actually setting it too low, and, you know, only time will tell on that. So. I'm going to duck now, Tomas.
Yeah, Andy, thank you so much for coming.
Can I chime in for 1 second though? I totally agree, John, but like unlike telemedicine, where you can begin to substitute data collection and sensors with a digital stethoscope and blood pressure, we haven't yet figured that out. So I agree there's going to be all sorts of trade-offs in that human element. We haven't figured it out in the classroom.
Yeah, I agree.
Can I offer one reaction? I think it partially relates to how the teaching is taking place. If it's conventional expository teaching, me teaching you, then we're doomed anyway. But the projects that I've seen and participated in, both either in the classroom or digitally, that are engaging and that where there's space, I just put in a couple of links in the conversation chat. There has to be space for that. Like literally, if it's a lecture and then comments and then you're done. If there isn't space for open engagement and for exploration and discovery, then whether it's in a classroom or virtual, it won't matter. It won't happen.
Yeah.
And just look at the links when anyone has time. Look at the links I posted. 2 moments during our webcasts when extraordinary things happen, and people's hair prickled, and you want to hug the person. You know, it's there. The capacity to hug and feel emotion and build connections is there. It's never going to be the same, but it's doable.
It's interesting because we have somebody here who has been talking about telemedicine quite a lot, and who's been experiencing some of the challenges and opportunities about it. So Bob, obviously, I think you've written about this too, and so I'm curious what your perspective is on this.
Well, I guess I was reacting to, I thought your way of framing the deconstruction of the office was really quite smart, because you're right. I mean, we don't even recognize that you've bundled all of these activities into one. I'll give you a little bit of a cautionary note from medicine, then I'll spend a second on telemedicine. But I wrote a book about technology in medicine a few years ago, and one of the observations that I made was that in the old days, the doctor like me would go down to the radiology department to look at our films. And while we were down there looking at the x-ray, we would have a chat with the radiologist. And it was wonderful and nuanced, and they would point out things that you just could not glean from their report, and they'd ask you about the patient. It was really quite a terrific and important interaction. Now, when I suggest to my young residents that we go down to radiology to look at the films, first of all, they look at me and say, "Don't you realize we don't have films anymore? We have computer images. Why would you want to go down there?" And so as a generation moves on, they never knew what the sort of breadth and depth of that conversation was, because they never had to go to, this was a forcing function. The only copy of the film was one single x-ray that lived in the radiology department. So you had to go down there to look at it. You might as well talk to the radiologist. And so they don't know that there's some richness of that interaction that has gone away. So I suspect that as you sit here at time zero and say, well, let's deconstruct what's in the office or in the classroom, and how do we resurrect each of those pieces? As you move away from time zero, people will forget what those pieces were. Yeah. And some of them will not be reconstructed. They simply will be lost. I couldn't agree more than with John about if telemedicine is just a visit replacement, it's sort of trivial. I mean, it's nice because it takes away the geography. Sorry about that. I'm actually at a hospital, and so they have ambulances here. It takes away the geography, but does not really change the fundamental nature of the interaction. And I think, as you were mentioning, Tomas, ultimately what really changes it, or maybe Andrew said, what really changes it is when not only are we having this interaction through telemedicine, but we're also looking at data that being derived from all sorts of other sources, and we're trying to figure out how to manage this deluge of data. It used to be that when I saw a patient in the office, that was the one time I checked their blood pressure, I checked their sugar, I checked their weight. Now, we can be checking those things through a digital feed all the time. The problem is if we turn that feed on today, and all of a sudden, all of that data is flowing into the primary care doc. I hear people periodically say how wonderful that's going to be. I can tell you that my 200 primary care docs will quit by 5 o'clock this afternoon if we turn that on, because they'll be overwhelmed in about 10 seconds. And so it's really, and I guess one last point, and then I'll shut up. The history of technological innovation, of course, as many of you know better than I do, is humans are not creative enough to take advantage of the technology, so they just replicate what they used to do. And that's why the doctor's note, for example, same example or parallel example, John, the doctor's note on a computer system, $100 million computer system, the note that I will write, and I'm writing this afternoon about my patients, looks like a piece of paper under a tab. Why? Because that's what it looked like when it was a chart. And of course, that's why we need young people around who say, why the hell are you doing it that way? Haven't you ever seen a Twitter feed or a Wikipedia page or a Facebook wall, and where's the audio and where's the visual and where's the interactivity? You need to sort of take the step back, but it happens in every technology that the first generation is simply a digital re-representation of the old way of doing it. And that's why it takes 10 years to really innovate in these fields. You've got to get past that and then say, this old way of doing it was silly and was bounded by the capabilities. Now that we've unbounded it because of all these opportunities, we can do something fundamentally new. Nobody's ever smart enough to do that right out of the box.
Bob, I want to just jump in and talk about that other trip to the basement that has long gone. I'm sure you remember the days of the bag of ice and the glass syringe and a radial puncture for blood gases. And now, that's long gone to pulse oximetry in many instances, and how refreshing it is. What I find interesting is that most people, let's even put clinicians into that, largely want the same but better. We want a cephalosporin with an expanded spectrum, or a cephalosporin that has a better safety, GI tolerability. But when it comes to new, it's a little scary. And I think that's what we're seeing now. We're not seeing the same and better in many instances. We're seeing new and different. And I think that just plays into the psychopathology of change, whether you're a teacher or a physician.
There's an interesting meme in tech around I think it's the unbundling of crate lists, and that's an equivalent for Excel, where it says you see crate lists, which was really an online version of newspaper, like potential articles and each one of these sections in crate list became an opportunity for $1 billion company. And the same thing happens with Excel. You have all these options. All the services that Excel has, and each one of these becomes $1 billion company. And so to me, when I hear that, what I'm hearing is, oh my God, this is like 25, 30 years ago with the internet, or like 10 years ago with mobile, where you have this huge opportunity. Suddenly all these user needs are unfulfilled, and each one of them is a $1 billion company waiting to be made. So it's going to be interesting to see what happens in the next few years about it. So that's one of the themes I wanted to touch on. I definitely want to go back to it, but there's a couple more also that I want to touch before. One of them is around this theme that we've touched on the power of the citizen activist, right? And to me, that's one of these huge changes. And the way you think about it is, 4 centuries ago, 4.5 centuries ago, the press changes the way information is handled, and that is the birth of nation states. Before that, most of the communication is handled by, at least in Europe, by the church or the churches, and they have most of the power. At that point, with the printing press, the information changes, and it's spread mostly through books, which are printed in one language, and that makes these languages something very important, which was not as important before. There was a gradient of languages from, say, Brussels to Madrid, or to Lisbon. But suddenly, languages in regional areas coalesce in blocks, and those create the emergence of nation states. And before that, they were just states, right? But now we suddenly have nation states, and that is because of the information flows. And the nation state has been, up till now, is the biggest source of power in the world. But in the last few decades, it's been going dramatically down, right? And I think this power of nation states is replaced by at two levels, at the citizen level and at the supra-citizen level, right? And so you have organizations at the supra-citizen level, such as the International Monetary Fund, or the World Bank, or the World Health Organization, or Facebook or Google, that start having more and more power compared to nations, right? And right now we have in Congress a conversation about this, right? Because really, if we didn't have these behemoths in tech, we wouldn't be having this conversation around the power that they have. And on the other side, we have the citizen activist, where people like us can reach tens of millions of people in a way that even 5 years ago would have been completely impossible. And some of us are advising governments and telling them, giving them advice on how to handle the crisis, which is completely unthinkable 20 years ago, 30 years ago. And so this is a trend. This is not going back. The more, and it's coming because of internet, because of social media, because of mobile. And so the same way the press changed the balance of power, the internet and remote work and mobile are changing this balance of power, and it's going to take decades for that to be really, really felt. And so I'm curious, from your perspective, how are you seeing this evolution, and what are some of the changes that we're going to see? More important, what are some of the challenges that we're going to have? And one of them, for example, we've touched on, such as the trust, right? When you have 186 countries and you are in one of them, you just have to either trust or not trust yours, but it's the one. When you suddenly have 7 billion people and you don't know who to trust, which is one of the issues that we've seen during the coronavirus epidemic, how do you handle that? Any thoughts on that?
I can jump in quickly. I've often talked about the collective intelligence of any group of stakeholders. I've always found it very interesting that parents of children with cancer often have an almost encyclopedic knowledge of the disease. They know the clinical trials, they know their kids' bloods inside and out, and they just have this amazing ability to drive the emotional and cognitive component. Just to get really philosophical on you, and then it'll be my turn to shut up. that Aristotle framed up the 4 pillars of human experience. And he talked about these as sort of the fundamental aspects of our experience. And it was truth, beauty, morality, and unity. And to me, I see this emerging in technology and society today. The search for truth. I mean, what the hell is the truth when it comes to COVID or some of these things? Beauty as an aesthetic sense is extraordinarily powerful. The notion of morality as what's the right thing to do with respect to things like AI, and finally unity, that collective. So to me, in a way, it's going way back to these sort of fundamental truths that are helping me kind of frame the discussion up a little bit.
Make one quick observation that we also here particularly living in San Francisco, and there's a lot of parallels to AIDS and HIV that are made. And I actually wrote a book about AIDS and activism in 1990 after running the International AIDS Conference here. And it was just striking to see a population of patients who came to believe that nobody cared less whether they lived or died. And that unless they were advocating for themselves, the government was going to allow them to die, which was actually fairly truthful. And what I came to understand was that the preconditions of disease-specific activism really kind of required a disenfranchised group believing that, sort of having a pre-existing sense of togetherness and otherness, that we are in this together and nobody cares about us, and that they are specifically targeted by this disease, and therefore if we are not take on the role of activism, nothing's going to happen. And they were right. And as John said, sort of they were like the parents of the kid. They knew more about the disease than many scientists. Fauci talks about his run-ins with the activists in that era. But they quite effectively advocated for massive resources for HIV and AIDS that goes on to this day. There's not been any hint of that in COVID. If you think about the incompetence of the governmental response, if you had anything, if there was a disease-specific group that was targeted by this, and you can argue that the disparities demonstrate that it's actually being targeted to underserved populations and minority groups, but none of them have sort of gone up and said, the government is killing us. It's really actually been remarkable how little activism has been generated by the lack of an effective public response. And I suspect it's partly because of the ubiquity of the risk groups. It's not that it's targeting one person, it's sort of targeting all of us. It's targeting all of us at a level of risk that none of us sort of feel so like I'm going to die if something doesn't happen. The difference with AIDS in the beginning was it had a 100% mortality rate. You were going to die. And so you have everybody, the risk is sort of slathered across everyone. The only people who are super high risk are 70 or 80 or 90-year-olds, and they're probably not capable of activism, although it's interesting to see that groups representing older people have not sort of become more active. But I'm struck by the sort of limited amount of public activism pushing the government to do more. It more falls along sort of traditional political lines, and it's sort of whether you're wearing shirts or skins. And I think that's partly because it's sort of it's focused on everybody. We're all at risk. There's not one group that could sort of take this and say, if we don't do something, we are going to die. It's a very different dynamic.
And Dr. Oh, sorry, I just had a quick comment to Dr. Watcher. I was thinking potentially, I was wondering if it may be because of it, just looking at San Francisco and looking at the cases and where they are, it is minority populations that it is within the Latinx community. And a lot of them are undocumented, and there is this fear of government and fear of coming out within that community.
Yeah, probably part of it, probably, maybe a little less organization, and probably because we're talking about a significant relative risk compared to, a Caucasian person, but not a sort of massive risk for any one individual person, to the point that it consumes your life, as it did if you were a gay man in San Francisco in 1985, where you were seeing friends die all the time, and you knew that if something different wasn't done soon, you were probably going to die of it too.
I was just going to say that I agree with you, Bob. I think that because people are not being singled out in the way that the gay community was in the early 80s, there hasn't been an activist movement coalescing around that. But I also think that it's gotten to the point where it's sort of beyond just COVID activism, because the pandemic has been so politicized. It's very difficult. I mean, I've had a number of people ask me, oh, are the Black Lives Matter protests associated with increased COVID transmission? And the truth is, it's very difficult to say whether that's the case or not, because cases, especially in communities that are heavily affected and surging right now, you're never really going to be able to do contact tracing at the scale that you need to do that to try to investigate a particular outbreak, where you might be able to trace it back to either a protest versus a bar that reopened too quickly. So I mean, we are seeing a lot of activism, sort of unprecedented activism about these other political issues that are really intersectional with both the COVID pandemic as well as these other major public health issues like systemic racism. But I think it's really difficult to separate sort of like an ACT UP type organization just for COVID, because there are so many other political considerations that have become part of this discussion, I guess, as a society. Mm-hmm. I do see, there are some sort of fledgling activist movements. There's the One Day Sooner advocates for coronavirus vaccine human challenge studies. And they are very well organized. They've collected a lot of funding, and they've actually hired some full-time employees, and they've reached out to me because I've been a pretty vocal opponent of doing human challenge trials. And they are trying to foster discussions with people like me who disagree that it's a good idea. And they are being organized in their efforts to do that. But I mean, I think you're right overall that there's not really a specific COVID activist movement, just because this is so integrated now into so many other aspects of our life and our sort of national identity.
Mm-hmm. The one point, this is where I'd like to make the point about one of the challenges right now is that there's multiple disasters, and there actually is a very active, and the word unity cuts in different directions. Those who are anti-vaxxers, and those who are anti-lockdown, because they either feel their economic circumstances were damaged or they are culturally politicized. they're very powerful, and they've used these tools incredibly effectively. And that's this part of the infodemic question that I've been doing, probably done 20 of these sessions on. So the other challenge, whether it's in pedagogy or just in making the most of these tools in this moment, is that, like with too many things, they serve both purposes, and you can aggregate anybody right now really effectively, and that's what leads to a lot of that harmful impact on people like Angela online. So it cuts in two directions.
So just to add a piece to that, Andrew, is the other piece of it is that clashes with the notion of morality, is that we actually have people who are actively using these tools and technologies to create misinformation.
Yeah, for sure.
Not an accident, right? And things are being done deliberately. So you have anti-vax, you have anti-climate change, you have a whole series of things where people are actively deliberately creating confusion, and that hurts this problem. So back to Thomas's sort of meta point was like, where is all of these things going to take place? Until we figure out how to validate information and its source, and teach people literacy around some of those things. So some of it is literacy, and some of it will be some technical solutions to validate actual sources of data. We're going to be stuck in this sort of weird place where we are spinning our wheels to some degree, trying to figure out what truth is.
I agree with you, and unfortunately, I think that's translated into one of the biggest challenges that we have right now about the coronavirus, besides just masking. But it's something that people don't talk too much about, and I think it's crucial. Right now, the economies of Taiwan or South Korea are completely open. And the reason why they do that is because they were able to prevent cases from coming in. Once they're in, they have masks and things like that that reduce the spread. And also, they're very good at if somebody does catch it, they identify that person and they isolate that person. And you need these three pieces. You need to prevent people from coming in, lowering the spread once they're in, and then if they catch it, isolating and like identifying this person and quarantining it. And both in Europe and the United States, that last piece, I don't think we're doing really well. We are doing so much more than we used to, right? Testing, and we have contact tracing, such as Rikita. And I think for me, that's one of the reasons why I highlighted the ratio of out of all contacts, how many of them can we quarantine? Because from what my understanding has been by talking with epidemiologists, by contact tracers, is that actually there's a pretty low percentage of them that I actually get quarantined, right? We reach some of them. Some of them we try to, we give them resources sometimes to isolate or quarantine, but the success rate of that is low, partially because so many people don't want to be contacted, are scared, or just don't believe in this. And so I wanted to ask you from your perspective, everybody, obviously, Rikita, you've talked with a lot of people directly about this. What are the pitfalls that we're seeing in isolations and quarantines? Are these actually happening? And then more broadly speaking, is this a problem that is social around trust of the government or some other thing? And what can we do about it?
There's so many challenges. I mean, our primary way of reaching folks is on the phone. I mean, how many times do you actually pick up a phone for a number that you don't know? And especially if you're a minority population, you're undocumented, things like that, there is this fear. And you know, we're trying to address some of that. There are some public education campaigns in the city. Things are being broadcasted on the radios saying, you know, it's okay to speak with us. We're not going to disclose your information to anyone. There's no like risk for you. And we try to be upfront with that when we're talking to someone on the phone, so they're a bit more comfortable. And they also, you know, will give information to us. And also we offer resources to folks. So we do offer food. We do offer isolation and quarantine hotels for folks that, you know, can't isolate at home if they're, you know, living in a multifamily household and things like that. So we're trying to get at that, but it is challenging. And, you know, I think, you know, we are trying, since our primary way is the phone, we're trying to think of other ways. Maybe there needs to be more of a field approach that we actually, you know, have field contact tracing teams that can sort of go out to the community, especially when we know that there's, let's say, 20 people living in one household. Maybe we just need to go out there and test everybody. and sort of just have that approach. We did that with Ebola, we did that with other diseases, and I think what's challenging with COVID is that we just have to act fast. Speed is queen, and we're not typically used to working in that capacity. So
it is. I have to say, I know that's right. What you're saying is true. It is scary because San Francisco is at the top of the country, and if this is where the situation is here, it is scary of what happens in other places. I don't know if anybody wants to comment on this topic. Otherwise, I have a final topic to bring to the table. And I think it's
at least
yes,
according to the, it'd be interesting knowing from Rikita, but according to the San Francisco, website, they say that you guys are contacting about 80% of people. Other parts of the country, when you look at the success of contact tracing, it's often 10 or 20%. So is that right? You're actually ultimately able to get in touch with 4 out of 5?
We are. We're real, and I think a part of it is our training. Most of our workforce, they speak Spanish, or they, speak other languages. We're also mobilizing community-based organizations to actually support contact tracing. So it's not just, while we have a huge workforce of librarians, we're also getting, community members involved. So we are actually reaching that point right now. So I think there's still work to be done. I think that percentage might go down given the number of cases recently.
And of course, the efficacy of the whole thing depends on testing. That if you can't then test people and get it back the next day, the whole thing.
Exactly.
The value goes way,
if
way
one
down.
piece is broken, the whole system sort of affects everything.
Hopefully you're right, and we are getting better, and the rest of the country follows suit. I think for the last question, it's a personal one for each one of you. A lot of your personal lives have been upended, like for everybody else on coronavirus, but especially for you because you've been so close to the epidemic. And I'm curious about you. What opportunities have emerged from this situation, and how are these opportunities making you rethink your future?
Okay, well, I can start. I was actually on the academic job market when this pandemic started, and you might think that that's a great time to be looking for a job as a virologist, but turns out that it's not, because all the other virologists who would normally be on the academic search committee are kind of busy right now. So, not to mention, I mean, there has been a lot of funding, but a lot of it's very short-term funding, so it's hard to say how sustainable it is. So I've been thinking about, and I'm actually right now, I realize that I'm non-tenure track faculty at Columbia, but I'm in Seattle right now, and that's because my husband lives here, and I decided in March that I would rather ride out the pandemic with my family than by myself in my 5-story walk-up apartment in Manhattan. So I've been trying to think about how I can contribute to this. And fortunately, a lot of my research involves computational analysis. So I have been able to continue working on actual virology of SARS coronavirus 2. But the increased Twitter following I had, I mean, I started the year with 250 Twitter followers, and now I have 154,000. It's been really surreal, and I'm trying to understand ways that I can leverage that platform for good and to help educate people about this terrible circumstance that we're all going through right now. I mean, this is really a generational pandemic, and if I can help others, well, first of all, be more science literate in general. It certainly will help me explain to people why you need to advocate for increasing the NIH's research budget. But it also, I think, just helps people understand like how something like this can affect everybody's life, and how, one of the antidotes to convincing people who are staunchly opposed to wearing masks or social distancing or stay-home orders is to build trust with them, so that you can educate them on why those things are important and why they're good public health measures. So I've been really trying to make time for science communication, both so that I can hopefully educate people and give them a little more context about this virus and what we know, and more importantly, what we don't know and what we need to find out and how this is going to impact their lives. But long term, I mean, hopefully we can be part of a society that really values this type of research, because I think avoiding another pandemic from another novel emerging coronavirus, of which there have been 3 in the last 20 years, is really contingent on getting people on board with the notion that this is something that's worth investing in. So that's really kind of what I've been doing. And as I mentioned in my lightning talk, you know, I have had a lot of great opportunities to connect with many of my colleagues, both other virologists and across disciplines, and really form some cool, like, multidisciplinary partnerships to seek funding and do really, hopefully, very transformative work on emerging viruses going forward. So overall, I mean, it's created a lot of really new opportunities, even though it's been just as difficult for me anyways, as I think it has been for everybody else, trying to get through these uncertain and surreal and very difficult times.
Angie, thank you so much. And I am so frustrated because I actually wanted to hear from each one of you on this, but I'm being told that we're going to be kicked out. So thank you so much. And in fact, I do want to hear from all of you. So I will reach out because I really want to know. But thank you so much for being here, for sharing your perspective. And I look forward to hearing more from you in the future.
Thanks for doing this.
Thank you all.
Thank you so much.
It's been a pleasure.
Thank you.
Sorry, everybody, for getting the last word.
That was a good word.
Thanks.